Hello, everyone. We're going to go ahead and get started. So good morning, good afternoon, and good evening, depending on where you are calling in from. My name is Allison, and I'm a Senior Program Associate on the Primary Healthcare Performance Initiative. Thank you for joining us today, and welcome to this webinar, which should last approximately 1.5 hours. Before we get started, I want to quickly review some notes on connecting to the audio and visual presentations during the session. We're using WebEx as our webinar platform, and you can join the webinar either via telephone or internet connection. Once you join the webinar, as you see on the screen, be sure to select your audio source from the pop-up menu. Something we found from experience is that using computer to watch the presentation while using a phone to call in tends to provide better sound quality. Next, I'd like to mention that the WebEx platform has both a chat and a Q&A feature found in the top right-hand corner of the WebEx screen. Clicking on this will bring up a small panel on the right side of your screen. Be sure to use the chat feature if you're having trouble with your connection, and our team will do our best to help you troubleshoot any issues. And you can use the Q&A space to note any questions that you have during the presentation. We'll take time to field questions towards the end of the webinar, but we encourage you to submit them as they arise. When submitting a question, please note if there's a specific panelist who you would like to answer the question. We also ask that you keep your microphones muted throughout the webinar and only use the chat or Q&A features in order to reduce background noise. And kindly do not use the video option, as this will help ensure the quality of connection for all participants. Please note that this webinar is being recorded and will be made available online. So with that, I'd like to welcome you again to the Primary Healthcare Performance Initiative webinar, Measuring What Matters, Data Innovations for Strengthening Primary Healthcare. The Primary Healthcare Performance Initiative, or PHCPI, is a partnership between the Bill and Melinda Gates Foundation, the World Bank Group, the World Health Organization, with technical partners Ariadne Labs and Results for Development. We're a partnership dedicated to transforming the state of primary healthcare, or PHC, striving to create a world in which strong primary healthcare is a reality and not the exception for every person, family, and community. Our aim is to use measurement for improvement and accountability. We work closely with governments and development partners who are looking to strengthen primary healthcare, providing them with the data, information, and support that they need to bridge the gap between measurement and improvement by providing relevant and useful information on what works to improve primary healthcare. The inspiration for this webinar came from a report published by PHCPI on Universal Health Coverage Day this past December. The report featured a collection of 7 case studies across 5 countries detailing how data innovations were being used to drive improvements in primary healthcare. Each case dealt with different elements of how data can be used for improvement, from the creation of high-quality indicators and the collection of actionable data through to the analysis, use, and dissemination of these data. Our goal with this report was to provide a sample of the many ways countries are using evidence-based decision-making to improve primary healthcare quality and service delivery. We're delighted to be joined today by representatives of 4 of these case studies who will be telling us a bit more about their respective innovations and the ways in which these programs are using data to drive primary healthcare improvements. We will be hearing from Dr. Kokou Awunar, the Director of Policy Planning, Monitoring, and Evaluation of Ghana Health Service, who will be sharing more with us on the CHIPS Plus innovation. From Ms. Jamie Chung, the Director of Operations at Babel Rwanda. Ms. Melanie Joyner, a Senior Technical Manager at IntraHealth International, who will be delivering a presentation on the Yexina project in Senegal, and Dr. Omi Kalsoum, the Director of the Yexina project in Senegal, who will be available to answer questions during the Q&A section, and Ms. Ramon Sohal, a Senior Strategy Advisor of North Star Alliance. We are also joined by Dr. Jeff Markins and Dr. Laurel Hatt, both from PHCPI, and myself, Allison, who will be your moderator today. Our agenda today will follow the basic outline of the Measuring What Matters report, but will be an opportunity to gain a bit more depth into some of the innovations featured there. We'll begin with a discussion of the role of data in driving improvements in primary healthcare, followed by presentations on the 4 innovations. We will then move into a brief discussion about how PHCPI is using some of the key insights gained from work with innovators to accelerate improvements in primary healthcare across all countries. And finally, we'll have time at the end for a discussion section where we'll give listeners the opportunity to ask questions directly of our speakers. I'll now invite Laurel Hatt to discuss the role of driving improvements in PHC. Laurel is a health economist and evaluation research expert at Results for Development. She's the program director for R4D's portfolio within PHCPI, and she has helped develop tools for PHC measurement and improvement. So Dr. Hatt, over to you.
Thanks so much, Allison, and thanks everyone for joining us today. Welcome to this webinar. Before we can discuss the importance of data in driving improvements in primary healthcare, we first must consider what the elements are that define strong primary healthcare. Within PHCPI, we've identified 6 key characteristics of strong PHC. These include serving as people's first and main entry point into the healthcare system and a source of care for most healthcare needs, the delivery of a broad spectrum of preventive, promotive, curative, and palliative care, management across levels of the health system, including effective referral mechanisms and efficient methods of follow-up. We also know that PHC should be centered around the unique needs and expectations of the populations it serves. It should have the capacity to serve patients continuously throughout their lives, and it should be accessible to communities at prices that they can afford. We've defined strong PHC as not just the provision of basic services, but as an integrated approach that addresses the majority of health needs across the population at all stages of life and forms the foundation of efficient, equitable, responsive, and resilient health systems. Given these core characteristics of strong PHC, we know that the role of data in strengthening and improving PHC is pivotal. When we refer to data in this context, we're referring to the complete data value chain, extending from the creation of indicators and the collection of inputs all the way through to the compilation, analysis, discussion, and dissemination of these data. We know that clear, actionable indicators help health system managers, policymakers, and technical experts understand how care is being delivered, including, for example, how supplies are moving through the health system and the quality of care that patients receive. We also know that comprehensive evaluation frameworks can support innovation by allowing technical experts to recognize improvements and develop successful strategies for scale-up. And when these findings are communicated to the public, they can empower communities to take an active role in holding their providers accountable for high-quality care. And finally, we understand the importance of interoperable data systems, those that can send and receive information between platforms, in allowing for care to be delivered continuously to ensure that services are available at a time and location that works best for each patient. The important role of data in driving improvements in primary health care is clear, and many countries and implementing partners are leading the dialogue about how these innovations can be used to improve the quality of care for patients everywhere. We are very excited to have leaders with us today who are working at the forefront of this space, and I'd now like to hand it over to the representatives of these innovations to learn a little bit more about some of the ways that data is being used to drive improvements in PHC.
Thank you. And I'd like to echo that excitement about having representatives with us today who are working at the forefront of data innovations for PHC improvement. So in order to learn more about how countries are using data to drive improvements in PHC, I'd like to welcome our first speaker, Dr. Koku Awunar, who will be speaking to the CHIPS Plus program in Ghana. Dr. Koku Awunar-Williams is the director responsible for policy, planning, monitoring, and evaluation of the Ghana Health Service. He has almost 3 decades of experience in senior health management in Ghana, including 16 years as the district medical officer and 8 years as regional director of health services. Prior to that, he had been the national coordinator for Ghana's community-based health planning and services initiative. He is a public health physician with an MD from Minks State Medical School, an MPH from Leeds University, and a master's degree in health policy and administration from the Ghana Institute of Management and Public Administration, and a PhD in epidemiology from the Swiss Tropical and Public Health Institute. His interests include health systems development and evaluation, childhood survival, reproductive health, and health systems for marginalized populations. Thank you, Dr. Awunar-Williams, for being here today to share with us some of the successes of the CHIPS Plus innovation.
Thank you very much, Alison, for the opportunity to make a presentation on Ghana's program for data used for decision making. So basically, my presentation will focus on how Ghana is using what I call implementation science program to generate evidence and use the evidence to strengthen our primary healthcare provision with a focus at the community level. Now, just a bit of a background about Ghana's primary healthcare system. Our PHC system in Ghana is basically structured, as you can see from the slide, in 3-tier system. That is from the community level through the sub-district to the district level. So level A basically is the community level where the focus of this presentation is. And this is where we have our CHIPS program. The community level is the first level, and PHC is delivered through an internationally celebrated strategy, what we call CHIPS, the Community-Based Health Planning and Services program. It is basically a strategy to deliver essential community-based services at the community level that involve the planning and the delivery of the services by the community members. Next slide. Now, having implemented this program or strategy since 1999, after 2 decades and over, we realized that the original intention is that we should reach the entirety of Ghana's population by 2015. But however, by 2008, we realized that we were only covering just less than 13–14% of households in Ghana with this program. What we did as a ministry was to do a formal evaluation to see what are the bottlenecks, what are the challenges, why are we not achieving our goal. And then the findings from this study revealed that it would take Ghana almost about 5 decades to be able to achieve a total coverage of PHC in the entirety of the country. What this meant was that if we're going to achieve UAC as currently outlined, it means that Ghana will be able to achieve UAC by 2050, meaning that even 20 years beyond the 2030 target. We realized that we didn't have the time to wait. The problem wasn't only the scale-up rate, but also the translating the service to improve health outcomes. At the time, you are all familiar with the MDG, so there was a much concerted effort to improve maternal and child health outcomes, and so that was the focus. So these are the challenges that led to the design in terms of the innovation, what we are now calling CHIPS Plus. So what did Ghana do given these implementation challenges? What we did was to go back to the design board to look at the entirety of the strategy. What the earlier trial did was to test effective strategies for delivering primary health care. But this time, the objective was to explore what other strategies are available for us to be able to enhance this strategy. And that's what comes in what we call the Ghana Essential Health Intervention Program, which is a CHIPS-related program, which is called the GEHIP project. Now, GEHIP basically identify how the scale-up of chips will be done using a number of interrelated interventions that are targeted basically at different health system building blocks. So a key strength of GEHIP was the centrality of measurement, which focused on routine monitoring and formal evaluation. Now, what was the result of this formal evaluation? It meant that the scale-up strategies that were tested yielded almost 49% additional decrease in under 5 mortality when GEHIP was implemented. The most exciting finding when GEHIP was implemented was that we only needed less than 10 years, in fact, basically 5 to 7 years for national scale-up rather than the 50 years that was estimated from the survey that we did. Now that we have learned how to scale up chips using the proven strategies, what we did was to launch in 2006 what we are calling the Chips Plus strategy, which is the new, we call it the new block, the new kid on the block, sort of. Now, Chips Plus was meant to replicate what GEHIP did, basically the GEHIP model. That project was done in one of our regions, which is called the Upper East region, and the idea was to extend and scale this up in 2 new regions as a way of accelerating the scale up and improve the health outcomes of those 2 regions. Now, measurement for us was so important, and therefore, what the new program did was to improve on routine monitoring as a major activity, and then also formal evaluation to drive decision-making at all levels of the health system. So, next slide. So you can see, next slide, please. So you can see the kinds of approaches that were adapted for this particular CHIPS project. What has been these approaches to generate evidence for decision-making platform? Now, you realize that to enhance data collection and use at both the sub-national and national level, CHIPS Plus is utilizing 3 main approaches, and you can see from the slide. The first is simplified data collection. The second is improved data use, and the third is the impact evaluation. And I would like to discuss briefly into more detail these 3 subsequently in the subsequent slide. So next slide. Now let's start with the simplified data collection. What was done that you realize that you see a pack of registers there. Previously, our community health workers used more than 20 registers to collect data. So we did what we call the simplified register, where all these registers were simplified into 2-3 registers. Additionally, what we did was to roll out what we call the eTracker, which is a tablet-based electronic data capture system, which is integrated into our DHIMS2 system. And I will talk a little bit about more of the eTracker in the next slide. So the result that we saw was the improved data collection, data quality, and of course, the ease of data analysis. And we also share a lot of experiences with frontline workers on the usefulness of the eTracker, how it has taken away time from data collection to service delivery itself in the CHIP zones or in the community that they were working. Next slide. Now, so basically, just to give a few points on the eTracker. No, go back, please. Go back to the eTracker, yes. So first of all, I want to just make the point that the electronic data system, which is the eTracker, is interoperable with the DIS2 system that we have. We also realize that it reduces man hours that is needed for tallying service delivery data. It improves timeliness, enhance service delivery, and is able to filter out defaulters and for continuum of care when people move from one facility to the other. So the eTracker, as it is now implemented, has a lot of advantages and ease of use by our frontline health workers. The next slide. Now, what are some of the strategies that are being used for supporting data use? So we have what we now call the systems learning districts in these 2 regions. There are 4 of them. who now have their own active dashboard. You can see the dashboard on the right side that shows levels of completeness, levels of use, and levels of effectiveness in terms of data collection and completeness. Now, these SLDs now have their own dashboard on the DIMS2 platform. Indeed, what we did was to start in one of our SLDs and then eventually scale up to the other, what we call the system learning districts. The strategies to support data use include capacity building, using on-the-job coaching, in fact, which is preferred approach as compared to workshops, because people tend to learn more when they are doing on-the-job coaching. We have also supported data use through provision of guidelines and job aids. In fact, district supervision is also enhanced by this system, as they need to provide feedback on data that they collect and how this data is used for decision making at the chiefs levels. But perhaps the most powerful strategy for supporting data use has been the development of data visualization tools, as I said earlier. And here it's more of competition, but also looking at what we are doing at real time, so that you can make informed decisions whether you are meeting national targets. And these are coded in colors that are very visible, so districts get to know how they are faring, and they are able to see how other colleagues are also performing as far as the service delivery is concerned. Next slide. Now, we are using various approaches for independent impact evaluation for this particular program, including health facility assessments and monitoring of this process. And as you can see from the slides, impact evaluation are the main approach for generating the evidence that we need to guide revisions of the existing policies and guidelines, because here routine reports will not be enough to steer what we want to achieve, particularly in the direction that we want to go as far as UAC is concerned. Our benefit for the impact evaluation includes: one, it is more rigorous and independent, hence a more robust source of evidence for continued learning; and two, the population survey gives a more comprehensive picture, especially in areas where access is a problem and most people may not make it to the facility level. So you can see the impact evaluation. We are using population-based surveys. We are using health facilities assessments. We are using what we are calling qualitative assessment, appraisal, system appraisals, and also the routine process monitoring. Next slide. Now, in our system learning districts, what has been the impact of our program so far on primary health care? We realized that in our SLDs, there is improved data quality, particularly in terms of data completeness. There are no more challenges with data timeliness, also because the data is entered real time as the service is offered. We have also seen appreciable improvement in process such as using the data to plan at the district level, at the community level. Even at the most peripheral level, the use of dashboard, for instance, has enhanced the use of data for planning. For instance, if a community health officer is very much aware where they are falling behind in terms of the national target or the regional targets, they are able to look at that and know and use plans and strategies and specific actions to take to be able to address that and make the improvement that they want to see. Additionally, what we have also observed that the SLDs have become a hub to try out new innovations because of the systems that we have put in place prior to the large-scale implementation. Finally, let me say that the ultimate goal of the Chiefs Plus, beyond scale-up of Chiefs, is to achieve UAC. So, and this is to improve our health outcomes. We have reports of improved service coverages in the SLDs. We have enhanced tracking of defaulters. And so there's so much to talk about, there's so much to celebrate using this particular project approach to be able to drive, evidence for national system scale-up. Next slide, please. So what is the future for this project particularly? What we intend to do, basically we are documenting. If you see on the left side, making the system work is one of the documentation of the lessons to share the best practices and ways that service can be delivered better. So we have what we call the learning, making the system work. Part 1 is lessons that are learned on studying Ghana's primary healthcare system. We are also using, the part 2 is also looking at how do you develop an emergency public health system, which is ongoing. And probably we are thinking that from the lessons that we've learned from all these, the next will be to look at how does leadership, drive health systems effectively. So we're thinking that the next series of documentation that we should do will be looking at leadership for chiefs, most probably. So for now, this is what I would like to present, and I look forward to discussion. But I would like to acknowledge all the partners, next slide, who are part of this. Next slide, yeah, the Doris Charitable Foundation. We are doing all this work in collaboration with our universities, with Columbia University as well as University of Health and Allied Sciences in Ghana and University of Development Studies, as well as partners like JLN, PSCPF, WHO, etc. Thank you very much.
Great. Thank you, Dr. Aounar, for that excellent presentation. It's exciting to hear about the role that data continues to play both in the delivery of services through CHIPS Plus and in the scale-up of this innovation. I'd now like to welcome our second presenter, Ms. Jamie Chung of Babel, Rwanda. Jamie is based in Rwanda and is the Director of Operations at Babel. She was previously in strategy consulting and currently oversees the activities of Babel's commercial, marketing, and customer service teams. Over to you, Jamie.
Hi, Allison. Thank you very much. Let me share my screen. Okay.
Jamie, I think we can actually advance through on our side if that works for you.
Oh, yeah, sure. That sounds great.
Okay, great.
So can you put up my PowerPoint presentation?
Yes, here we
Great.
are.
Perfect, thank you. So hi everyone, as Allison introduced, my name is Jamie and I am presenting on behalf of Babel today on the role of data in accelerating innovations and how we see ourselves contributing towards that goal. So if you go to the next slide, please. I'll start off by giving a brief overview of Babel and our business model and how we've been operational since 2.5 years ago. So we started operations here in Rwanda in September 2016. And during that time, we have built a national digital health service for the entire population of Rwanda through mobile phones. As is the case in many other countries, accessibility to healthcare is a challenge, as patients in Rwanda often have to travel long distances to seek care, and also queues at health centers once they get there are often very long. Studies have shown that this results in a waiting time of up to 6 hours. And so we wanted to come into Rwanda leveraging our technology, leveraging the country's high mobile penetration rate of over 75%, and connect doctors over the phone to patients all around the country. But we also provide much more than that, which I will kind of walk you through and hopefully will become clear as we progress throughout the presentation. Since our operations began, we've registered about 30% of eligible adult Rwanda population and have completed up to 280,000 consultations to date. So if you could please go to the next slide. It outlines how, this slide outlines how we actually work. So patients are able to do all that they did in a health post or a health center through a phone. So what they do is, regardless of whether they have a smartphone or a feature phone, everyone who wants to use Babel services can register dialing *811#, and they go through a process where we verify their ID and help them book an appointment or through our USSD platform. Once that's completed, our nurse and or a GP calls the patient within a specified time, and the patient is alerted of what time that would be prior to the call through SMS. Some of our patients actually stop at this stage because they just seek medical advice, and at that point their journey is complete. But some patients actually require lab tests or prescription, in which case they receive a code for the lab test and the prescription through text messages. And they can take that to any of our health center partners, private pharmacies, and so on, depending on what sort of insurance they have, and redeem that there. So if you go to the next slide, I'll talk a little bit more about our primary healthcare facility partners. So beginning of February last year, we began to partner with a lot of health centers around the country. So you see the map of Rwanda on the right-hand side of the slide, and purple dots are all the facilities that we partner with. This includes about 360 public health centers, as well as 130 private pharmacies, and we're present in all 30 districts as of December, so 2 months ago. So how do we see, if we go to the next slide, please, how do we see the role of data in accelerating innovation? And how do we see ourselves contributing towards that? As I was thinking through it, 3 examples came to my mind that from 3 different perspectives. So I think the first one is around enabling better quality care for our patients through the electronic medical records that we provide. And then the second one is our ability to share high-quality data with our healthcare partners around the country. And then lastly, we also use data to assess constantly the quality of our product and service. So there's both kind of an external as well as an internal benefit that data provides in accelerating innovation and making sure that we're able to provide the best kind of service and product that we can. So now, over the next couple of minutes, I'll dive into more specific details around these 3 examples. So the next slide is the first box, Babo's contribution number 1, around enabling better quality care for our patients through electronic medical records. And what I did as I was thinking through this was understanding what the current status is today in Rwanda, and then also looking at how we have contributed or what potential we have to contribute towards changing the status with the goal of accelerating innovation. So when it comes to EMR, Rwanda has an interesting history. It decided to roll out a pilot program across 12 different districts in 2012. But my understanding is that each district has been using a slightly different type and module of EMR. So one district could be using, for example, a billing system, whereas another district could be using another type of a feature or a module of the EMR. And as a result, these systems across different districts couldn't really, quote unquote, talk to each other, which means that when a patient is born in one place, but then grows up in another place and moves to another place to work, that can be a challenge in terms of ensuring continuity of care. And it's also interesting and sad a little bit that this has affected some segments of the population more than others. So, for example, HIV-positive patients typically have to go to a separate kind of wing of a public health center here in Rwanda, which was meant to kind of provide specialized care. But oftentimes we find that a lot of patients deliberately travel for hours to receive treatment at a clinic that is far away from their home or where they work due to the stigma that they can often face. And as a result, when these patients travel to another district, it's oftentimes impossible for healthcare providers to actually know the person's medical history, their current care plan, most recent treatment, and so on. And so a lot of the patients start the treatment regimen all over again, which obviously has some implications for the treatment that they receive and the medical outcomes as well. And so looking at the current status and how Babo sees itself contributing towards changing this is Babo has the first fully integrated electronic medical record system that is also stored in Rwanda. And through this, we're able to build up a patient's medical history over time, regardless of their location. And I think also one valuable aspect of our records is that we're able to actually ensure a follow-up process, because our partner facilities all have to use our internal portal in order to help the patient redeem a lab test or a prescription, which means that we are easily able to track whether a patient has gotten the lab test or the medication that they were seeking at the time of consultation. This ensures that our GPs and nurses can actually follow up with the patients if necessary and make sure that they're receiving the best quality of care possible. And also, because every single consultation is recorded, it makes it very easy for us to conduct quality monitoring. And we have a separate team of doctors and nurses who just are staffed in a permanent team to ensure that all the audio recordings that they sample meets our quality standards. So that's a little bit on example number 1. If you could please go to the next slide. The next example is around sharing high-quality data with our healthcare partners. So currently, the lowest levels of data collection in Rwanda is done on paper at the community health worker level. And this data then gets aggregated at the health center level, and then the district hospital level, and then finally at the Ministry of Health level on a monthly basis. As you can imagine, because some parts of this process are manual, it's fairly easy for the data to be lost or damaged or tampered with. And sometimes this can lead to challenges in obtaining high-quality data and statistics. How Babel contributes towards changing the status through innovation is that we're able to provide real-time and accurate data to enable rapid decision-making. So, for example, on any given day, at any given hour, we're able to see how many patients are coming in from which district with certain conditions or diseases. And feed that information back to our health center partners as is necessary and relevant. And also through our technology, as I mentioned earlier, because we're able to monitor and share, monitor data related to patients picking up their prescription or redeeming lab test codes, we're able to also ultimately share data on stock management. So for example, our GPs only prescribe medications that all health centers should have in their package. But in the case that that is not available, we're able to extract data on that and potentially feed it back to our public healthcare partners so that they can take it into account as they plan their stock management process. In addition, I'd also like to mention that we contribute towards improving the data quality of our partners. So for example, we're actively working right now with the Rwanda Social Security Board on various aspects of their patient identification data, because we're noticing that there are some discrepancies between different data sets around the country, between different institutions. And this is part of what we see as our impact in ensuring high quality, consistent level of data across multiple partners. And lastly, if I could jump to the next slide, this is the internal angle on how we use data to assess the quality of our product and service. So a couple months ago, we commissioned an independent strategy consulting firm, Dalberg Advisors, to conduct an impact evaluation study of our work to date. And they found that Babel patients are highly satisfied with their quality of care. As you can see, 89% of our patients stated that they are highly satisfied, but also that we've saved patients a lot of time and avoid potential lost income, because 83% of our patients complete our journey within 1 hour. And Babel also serves all patients in Rwanda across districts and socioeconomic categories. So when they looked at our patient database, they found that our patient demographic largely mirrored the spread of Rwanda in terms of geographical distribution, socioeconomic categories, gender, age groups, and so on, which was great for us to hear. So those three are the examples that I'd like to talk about, that I talked about today, as how we use data and how we see ourselves contributing towards using that data to innovate primary health care. Thank you very much, and I'll hand it back over to you, Allison. Happy to take questions later.
Great. Thank you, Jamie, for that presentation. It's exciting to hear about the important role that mobile devices can play in improving service delivery, and to hear how Babel is really playing a leading role in achieving this. We'll now hear from Ms. Melanie Joyner of IntraHealth International, who will be speaking to the Yeksi Na project in Senegal. Melanie Joyner has been working in the field of international health for over 12 years. She joined IntraHealth International 2 years ago to support the Senegal portfolio, including the Informed Push Model project. Melanie, unfortunately, was not able to join us today, but shared a pre-recorded presentation that we will play. And during the question and answer section, her colleague, Dr. Umi Nadeau, will respond to all questions. Dr. Nadeau is a supply chain expert with more than 15 years of experience in the public pharmaceutical sector in Senegal, and she leads the Informed Push Model Project, also known as YEXI-NA in Wolof, having previously served as its technical director.
Good morning and good afternoon. My name is Melanie Joyner, and on behalf of IntraHealth, I'm pleased to share our case study on Senegal's supply chain system to strengthen primary health care as part of this webinar. To overcome supply chain challenges in Senegal, the Ministry of Health and Social Action and the National Supply Pharmacy partnered with IntraHealth, Dimagi, Merck for Mothers, and the Bill and Melinda Gates Foundation to develop the Informed Push Model, YEXI-NA, which helped to improve monitoring of health commodities to overcome supply chain fragmentation. We will cover these 4 main points in our presentation, starting with a description of the innovation, how it uses data to drive improvement, the impact on primary health care, and next steps. To begin, we will talk about the supply chain innovation known as YEXI-NA in Senegal. What is YEXI-NA? It means I have arrived in Wolof. It's a new distribution model which brings health products to the last mile. It combines the National Supply Pharmacy's YEXI-NA approach and the Informed Push Model, IPM, which regularly delivers products directly to the health facilities. YEXI-NA increases the availability of commodities at health facilities by establishing partnerships with private operators, otherwise known as 3PLs, improving electronic data collection and analysis, and defining monitoring procedures for stock. Before we continue, we wanted to provide some background and context prior to the implementation of YEXI-NA in Senegal. Back in 2012, there were many challenges in Senegal. The modern contraceptive prevalence rate was 12%. Unmet need among married women was 29%, and stockouts among public health facilities was 80%. In addition, there were difficulties in the previous payment system, whereby health facilities had to pay for their products first and sell later. There were also transportation challenges, which significantly impacted a health facility's ability to restock. And lastly, there was poor forecasting due to a lack of staff capacity, time, and tools. All of this meant that there was no accurate data on commodity consumption at higher levels. Following an initial evaluation in 2012, the Ministry of Health and IntraHealth launched a pilot of the Informed Push Model in 2 districts in Senegal. The pilot showed an immediate impact on the following indicators as shown in the graph. There was a reduction of stockouts of both Depo-Provera and Jadel at health facilities. And also, there was an increased consumption of contraceptives, over an increase of 38%. Lastly, there was an improved real-time data for decision-making and forecasting of products through an electronic logistics management information system. The successful pilot phase demonstrated the comparative advantages of IPM, which led to its expansion nationwide, now known as YEXI-NA. Additionally, there was the extension of electronic data collection and analysis through the ComCare application on tablets, which facilitated real-time data visibility and accurate forecasting at the health facility level. To date, YEXI-NA incorporates over 90 essential health products that are delivered directly to over 1,460 health facilities in all 76 districts in Senegal. This schematic helps to summarize the main ways in which YEXI-NA was able to transform the supply chain system in Senegal. First, by improving the system design, moving from a pull supply chain system to an informed push supply chain. Second, it helped to outsource commodity deliveries, moving from government health worker managed logistics to third-party logistics providers. Third, through enhancement of visibility of data, moving from paper-based to tablet-based electronic monitoring information system. And finally, the increased financial viability, moving from the expectation of upfront payments to post-consumption payments by health facilities. Today, we'll focus on the way Yexina used data to drive improvements. How did Yexina use data to drive improvement? Yexina uses a tablet-based logistics management information system that transfers data in real time to the district, regional, and national levels, which facilitates both accurate and timely reporting, as well as stronger forecasting and tracking. Third-party distributors make monthly deliveries of health products directly to facilities where they evaluate current stock and enter data into an online platform called CommCare, allowing their logistics managers to track consumption, trends, and forecast for future needs. Logisticians can also use historical data to determine the amount of product each facility will need and adjust as needed. This slide shows the data flow starting with the collection of health facility data by a 3PL private operator using the CommCare application on a tablet. The data is then synchronized with the server and then uploaded on CommCare. This facilitates the visibility of inventory as well as the availability of health facility consumption along the supply chain to quantify orders for each product. Consumption and inventory data are then available at health facility level and used to quantify orders, and also estimate cost recovery. In order to ensure data quality, paper and Microsoft Excel-based tracking tools are used at health facilities to corroborate the tablet-based inputs. Shifting the forecasting responsibilities from facility staff to logistics experts enables better trend analysis at individual facilities, district, regional, and national levels. Once a month, reports are compiled by each facility and shared with district health experts, head nurses, and midwives. Regional and national reports are also compiled regularly to report on trends and track progress towards national targets. Data analysis is undertaken at various levels. At the ministry, there's ongoing monitoring of health objectives for informed decision-making at a strategic level. At the national and regional pharmacy level, there's ongoing trend analysis to provide more accurate quantification of products. At regional and district team level, there's ongoing monitoring of consumption and stockout data of products. At the 3PL level, they conduct consumption data analysis to estimate quantities, verify stockout data at health facilities, and estimate cost recovery of sold products, as shown in this table for zinc. So what impact did Yexina have on primary health care in Senegal? Yexina streamlined supply delivery and improved service delivery through increased accessibility and availability of health products. Through increasing coverage of Yexina from 40 health facilities in 2012 to 1,460 health facilities in 2015, as well as increasing the range of products from 11 family planning products in 2012 to over 90 other essential primary healthcare products in 2015. Yexina also contributed to Senegal's impressive progress against the following key health indicators over a 5-year span between 2012 and 2017. Firstly, Yexina helped to reduce contraceptive stockout rates from 80% to under 2% in 2017. This helped to contribute to decreasing unmet need from 29% to 22% in 2017 and increasing MCPR from 12% to 26%. So what are the next steps? In terms of next steps, IntraHealth and its partners continue to provide ongoing technical assistance to support the Ministry of Health and the National Pharmacy cadres at various levels to implement Yexina procedures and LMIS. We're in the process of conducting a midterm assessment to track capacity building progress of different cadres implementing Yexina. And in addition, we continue to provide ongoing technical support to the National Supply Pharmacy to manage CommCare locally. And lastly, we expect that the National Pharmacy will take on contracting with the 3PL private operators by July 2019, sustaining efforts and gains of the YEXINA model. We'd like to thank Results for Development for including Senegal's YEXINA in their case study on data innovation for strengthening primary health care. Thank you for your time, and we'd be happy to answer any questions. Thank you so much.
Wonderful. Thank you to the entire YEXINA team for pulling together that presentation. And now I'd like to welcome our final presenter for today, Ms. Raman Sohal. Raman works as a Senior Strategy Advisor at North Star Alliance, a nonprofit organization that provides health services to mobile and hard-to-reach populations along transit corridors in sub-Saharan Africa. Over to you, Raman.
Thank you, everyone. Allison, I believe you have my slides?
Yes.
All right, great. So I'm going to begin by just providing a brief overview of our model and then describe how we curate data to facilitate evidence-based decision-making and programming. If we could go to the next slide, please. So the two founding organizations of North Star were the United Nations World Food Programme, the world's largest humanitarian organization, and TNT Express, a global courier company. North Star Alliance targets mobile populations, specifically long-distance truck drivers, sex workers, and community members along the transport corridors in sub-Saharan Africa. The organization started with the realization that in the 90s and early 2000s, truck drivers were disappearing faster than they could train new ones to enter the transport industry. It was discovered that the HIV/AIDS epidemic was decimating the ranks of long-distance truck drivers in local transport companies in Africa. The outcome of the alliance between WFP and TNT was North Star. Next slide, please. So in terms of our service delivery model, what we do is we look at the fact that most of these truck drivers are beyond the reach of traditional health systems and they're away from home for extended periods. Truck drivers are often vulnerable to illness and they're more likely to sex workers that are operating in and around truck stops and their host communities are also transient. Sex workers often do carry the added burden of feeling stigmatized, which can act as a barrier to health service utilization. Our clinics were established to reach out to these groups, and our service delivery model was informed by the logic if they can't get to healthcare, then healthcare needs to get to them. Next slide, please. Our clinics are located at border hotspots or ports where large numbers of trucks stop, load, and offload, and where sex work and informal trades flourish. Our clinics keep flexible hours, which are tailored to the needs of our target populations, and we have systematically identified disease hotspots along major transport routes in Africa. What we do is we bring services to these mobile groups in what we call roadside wellness centers, which are also known as blue boxes, containers painted blue. And from the outset, we've had a focus on cross-border activity and mobile groups. Next slide, please. Our model overall is informed by business process innovations, which has involved using standardized process of delivery as a means to drive efficiency in our operations. So what we've essentially done is used principles of logistics and supply chain management to develop a standardized blue box model, which involves using shipping containers to deliver healthcare to populations that are often neglected by and isolated from public health facilities. Shipping containers are branded and painted blue so that they are easily recognizable in different locations and countries. We also use a lean staffing model. Each clinic is staffed by either one nurse or clinical officer, a lay counselor, one security guard, and receptionist. And this lean staffing model, which emerges from the manufacturing sector, allows us to contain costs while still providing quality primary care. Next slide, please. In terms of our partnerships and our alliances, in every country in which we operate, we sign an MOU with the government and the Ministry of Health or the Department of Health. And so what we essentially do is we work in partnership with the government. And in fact, governments are one of our main sources of supply for medical commodities such as HIV test kits. And in Tanzania, the MOH actually uses our clinics as a means to enroll clients who are HIV positive onto antiretroviral therapy. Next slide. So in terms of our principles and values that drive our work, there are four. So first, we use an innovative and scalable model. Second, we are offering a healthcare delivery model that's providing access to hard-to-reach and mobile populations. We have many active partners that we work with, and these include stakeholders in the private, public, and humanitarian sectors. And we also recruit and deploy staff from the communities where our clinics are situated, and in essence, we contribute to local capacity building and livelihood generation. Next slide, please. One of our main objectives is to work hand in hand with national departments of health, and we do work to increase the capacity of national health systems to provide stigma-free service delivery to key and priority populations. And so this year we transferred 27 boxes to national departments of health in Southern Africa, and this was through a partnership with the Southern African Development Community, known as SADC, on a cross-border initiative on HIV and AIDS. And such efforts are one way that we use to really strengthen national health systems, to advance primary healthcare delivery, and ultimately to drive universal health coverage for underserved population groups. So to date, as of this year, we have 22 blue boxes in Eastern and Southern Africa. 6 of these are located in Tanzania, and of the 6, 3 are what we call inside the fence blue boxes. So these were clinics that were negotiated in partnership with transport companies, and they are solely for the use of long distance truck drivers, and they're in company parking lots, so they're not accessible to the public. The other 3 blue boxes in Tanzania are what we call outside the fence, and are accessible by truck drivers, sex workers, and community members. Next slide, please. So this is just sort of a summary in terms of the core innovations driving our success. So it very much is a standardized shipping model using converging shipping containers, a lean staffing model, and we use a lot of push strategies. So what we realize is that we can't simply wait for truck drivers to come into our blue boxes. What we found is that even though often we're at the border post or we're in the truck company parking lots, a lot of the truck drivers, they are reluctant to leave their trucks because it just takes 15 minutes before some of the fuel is taken or their cargo stolen. So we do a lot of outreach in the truck driver's cabins. This includes HIV tests on the spot and doing behavior change communication sessions. And then finally, we have developed an electronic medical record, which is cross-border. Next slide, please. So in terms of our service delivery model, one of the chief questions that was informing our model was how does an innovator such as Northstar design a model that addresses healthcare needs of mobile populations that are crossing borders? And because we were focusing on transient populations, this scale was built into our DNA from inception. And so we knew we needed a system and a model that would allow us to facilitate cross-border care, and that this model had to be low barrier and low cost. So over the last 10 years, what we've done is we've expanded our presence to over 6 countries along the transport corridors in Africa. And this expansion, our organizational expansion, has really been informed by the data that's been generated by an innovative electronic healthcare data system. And the system allows us to capture and store information on client demographics and service utilization. This system also allows clients to continue their treatment at any Northstar Roadside Wellness Center or Blue Box. And so this also ensures continuity of care across borders, which also increases healthcare outcomes and healthcare efficiency. Our healthcare data management system allows for routine monitoring, so which allows for real-time information to inform our management decision-making on performance, and it also allows us to make adjustments that may need to be made as we're implementing activities in order to achieve impact. Next slide, please. In terms of our service offering, what we do is we provide a basic package of primary healthcare services. And if we use the Starkville definition of primary care, what we realize is that we tick some of the boxes, but not all. Given that we target mobile populations that are transient, it is likely that they also seek care from other service providers. Thus, we're not always the first contact for our client groups for all health service areas. We do offer coordinated care, and that we refer clients with complex care needs to government facilities or other accredited facilities, and we do follow up on the referrals that are made. We offer a comprehensive package of care that encompasses sexual and reproductive health services and also select NCDs. What we've realized from the broader health services literature is that truck drivers are predisposed to a range of NCDs, in particular hypertension and type 2 diabetes, due to occupational health hazards. And what we find is that this evidence is certainly borne in the data in terms of the data that we collect in our clinics on long-distance truck drivers. So from inception, when we started, we focused largely on HIV and STI screening and then moved to treatment. And now, over years, we've expanded our scope of services to include the screening and treatment for select non-communicable diseases. And due to the fact that we have this cross-border EMR, we are able to ensure continuity of care for our client groups. Next slide, please. So in terms of our organization, we strive to be an evidence-based organization, and we routinely use data through monitoring and research activities to examine healthcare outcomes such as utilization and adherence amongst our populations. And we use this data to adjust and modify our activities and processes, and also to promote service uptake. Our current approach to monitoring and measurement is focused largely on monitoring outputs and outcomes. The data that is collected in the clinics is collected on a daily basis. It's analyzed weekly to identify factors that are accounting for the progress of healthcare indicators. We collect a significant amount of data on two key elements. First, we collect a substantial demographic data on the types of clients that are seeking our services. We collect data, for example, on clients' occupation, age, gender. And second, we also collect data on healthcare utilization, meaning the types of services that our clients are using. And this data that we collect in our blue boxes allows us to understand utilization and disease patterns across our Eastern and Southern Africa network. And ultimately, all of this data is critical in enabling us to understand our demand curve. We do collect impact level data, and we're striving to do this more and more. And one of the key impact indicators that we focus on is adherence. So we monitor the proportion of the WHO has dubbed as key and priority populations that are seeking services in our blue box clinics. Of those that are HIV positive, how many are adhering to their ART treatments? And of those that come into our centers and we are doing HIV testing on a quarterly basis, and we have been following them over a number of years, how many remain HIV negative? What we do know is that making effective use of technology is essential to successful healthcare management, and that a good EMR can help us collect, store, evaluate, and generate reports on client data and alleviate the burden of trying to manage this manually. We do experience some pain points in terms of the logistics of data collection, curation, and management, and one of the biggest problems that we currently encounter, and some of the other innovators touched on this, is a number of manual registries that are mandated by ministries of health that our clinic teams have to complete. And what we do find is that these manual registries significantly reduce our efficiency and decrease our ability to operate optimally. Next slide, please. So in terms of our results data, so these final two slides provide our results that we achieved in 2017. So in that year, our clinics saw nearly 190,000 clients across the network. We use a range of behavior change interventions, as I mentioned earlier, and outreach strategies to engage clients. And one of the core components of our service delivery approach is a peer educator model, where sex workers are trained to become educators and ambassadors for other sex workers. And this model is really used to facilitate the uptake of services by sex workers in the hotspots and brothels around our blue box clinics. And it's also used to increase healthcare awareness and social approval for behavior change. So in addition to the counseling, testing, and treatment services, there were around 120,000 clients that participated in these BCC sessions, and also 100,000 clients that received additional services through outreach sessions from our outreach teams. So we differentiate between what we call inside the box and outside the box activities. Final slide, please. And so this just provides a breakdown of the proportion of different client groups that access services, and also gives a sense of the type of services that they sought in 2017. So in sum, this is our model, and this illustrates how we provide a primary healthcare model to mobile hard-to-reach populations, and how we're using data and also data management systems to drive healthcare efficiency delivery. We are currently in the process of overhauling our EMR, because as we've scaled and grown, we've realized that our current system cannot handle the volume or the load. So that is sort of the next step in terms of our data management process and improvement. So I will stop there. Thank you so much for your time and for the opportunity to showcase North Star's work.
Great. Thank you, Raman, for that presentation, and thank you to all of our presenters today. I know I'm not alone in saying that learning about the ways these innovations are driving improvements in quality and delivery of care is incredibly exciting. I'd also like to note that even in these 4 varied case studies, working across different contexts and countries to solve different challenges, the role of data was pivotal. We've worked to distill 3 key lessons across these cases on the use of data in driving improvements in PHC. And the first of these lessons is that integrated data systems provide a comprehensive view of system performance and can help ensure that care is available when and where patients need it. We saw this across all 4 cases. In Ghana, the use of an e-tracker played an essential role in improving planning and accountability in the analysis of data collected through CHIPS Plus, and we also saw that this data is being leveraged through implementation science to accelerate scale-up. As part of Babel Rwanda, we saw that a unified patient record is incredibly important in ensuring the continuity of care between providers and across clinics. And we also saw that the use of an electronic medical record highlighted in North Star Alliance's work as a key mechanism through which services are able to be delivered to patients no matter which country they are seeking care in. And finally, in the Yexi Na project in Senegal, we've seen that innovations in an integrated data system can spur improvements in the health system more broadly, and that improving supply chain data collection and organization, Senegal was able to streamline the health commodity supply chain and ensure that essential health products and medicines were getting to patients when and where they were needed. Building on this lesson and underscoring the importance of integrated data systems, we see that coordinated and continuous care benefits from technology solutions that connect patients across providers and levels of care and effectively collect, store, and disseminate data. Again, this was seen in all 4 of the presentations we heard today. A common goal among these innovations was to strengthen the coordination and continuity of care, and we've seen that achieving this requires strong data collection, storage, and dissemination. And finally, we saw that strengthening PHC as the foundation for achieving UHC depends not only on the generation of new data, but on the better analysis and use of existing data to identify areas of weakness and develop innovative solutions. We know that evidence-based decision-making is essential for effective policymaking, but we also know that it can be difficult for decision makers to know which data should be used. Our capacity to collect large amounts of data today is better than at any other point in history, so it's important that we also have tools that can help us evaluate these data to draw meaningful conclusions. In each of the 4 case studies we heard today, we saw not just the collection of data, but the meaningful analysis, use, and dissemination of these data, and that across all contexts, improving the way we collect data will be just as important as the way we analyze and use these data. As discussed earlier, one of PHCPI's primary objectives is to work closely with governments and development partners who are looking to strengthen primary health care to provide them with the data, information, and support they need to bridge the gap between measurement and improvement by providing relevant, useful information on what works to improve primary health care. I'd now like to welcome Dr. Jeff Markins, PHCPI's Deputy Director, to share a bit about how PHCPI is using the key lessons learned from implementers working across countries to accelerate improvements in the use of data for strong primary health care. Dr. Markins, in addition to being the Deputy Director of PHCPI, works as a practicing family doctor at Boston University, leads their master's degree program in health professional education, and continues to head their Global Health Collaborative, working on primary care capacity building through family medicine in Southeast Asia and Southern Africa. Thanks for being here today, Jeff, and over to you. having some sound issues, so bear with us for a moment as we troubleshoot this. No. Okay, so in light of some connection challenges we're having at the moment, I'm actually going to hand it back to Dr. Laurel Hatt to tell us a bit more about how PHCPI is using common lessons to accelerate improvements in health systems across all countries.
Okay, we'll do my best. So we wanted to share just a quick overview of a tool called the Vital Signs Profile. This is PHCPI's signature tool right now to capture performance of primary healthcare systems. It gives a visual snapshot of primary healthcare system strengths and weaknesses, and this really helps policymakers, technical experts, and health system managers basically be able to distinguish the signal from the noise by highlighting the best quality information and helping to focus attention on the most critical components of system performance. Ultimately, the objective here is to help leaders be able to focus their reform efforts more effectively and inform deeper analysis. The Vital Signs Profile includes 4 dimensions, in addition to sort of an overview of the country's context, some basic background statistics on poverty and income, life expectancy, and various health outcomes. It covers 4 domains, the first of which is financing, looking at how much governments are allocating to primary health care, as well as specifically the amount of total primary health care spending per capita. This uses data from the System of Health Accounts and answers questions such as, is the government spending enough on health? Is enough being spent on primary health care in particular? Is spending on primary health care sufficiently prioritized? And what sources are funding primary care? The second dimension, the capacity dimension, uses a mix of qualitative and quantitative data to try to determine the performance of governance systems, whether there are policies that prioritize primary health care, the status of input systems, whether there's enough staff, workforce, health infrastructure, and basic inputs such as medicines, and also how well the facilities are being managed and responding to the needs of the population, whether facilities know their population, promote good teamwork, and are well managed. The third dimension is around performance, and this uses data from globally comparable surveys when that data is available, and from local country data sources when it's not. With that data, we develop 3 indices: an access index that looks at whether patients can get care with minimal financial barriers or long distances, a quality index, which looks at whether staff can diagnose and treat basic conditions and achieve good quality of care, and coverage, service coverage. Are patients able to receive a wide range of essential services? And finally, in the equity domain, we use data from the WHO's Health Equity Monitor to look at differences in perceived barriers due to cost based on wealth, RMNCH services provided based on mother's education, and differences in outcome in child mortality by rural or urban residents. Based on these pillars, we hope this will provide country leaders and international partners with better information on how well primary health care systems are functioning in a country, and allow them to identify areas they might want to target for interventions towards improvement, much like the programs that we've heard about today. And to assist with this, we also have a series of improvement strategies listed on our website, which is improvingphc.org. Each of these strategies is intended to link with specific areas of the vital signs profile. Over time, we hope to promote additional opportunities for sharing experiences and joint learning in primary health care measurement and its role in the path towards improvement.
Wonderful. Thank you, Dr. Hatt. And now I'd like to open it up to our listeners for a discussion, question, answer section. So as a reminder, you can send questions through the question and answer feature on the right-hand side of your screen. It was also recently brought to our attention that not everyone has the Q&A option pop up for them, so you feel free to also submit questions through the chat feature. We have one question lined up already that has been sent through for Dr. Kokou Aounar from the CHIPS Plus program about the e-tracker that CHIPS uses. Can you please speak to whether the e-tracker for CHIPS is a government tool, and does the government fund community health workers to use this tool, and is the e-tracker only available to government health facilities? Thanks.
So thank you very much. Let me just, the e-tracker is a government tool. It's part of the health system DHMS design. Currently, we have deployed in not the totality of Ghana, but in only 2 regions. We are now setting up in the 3rd region. It is used by both the government system at the CHIPS level, and if there is a quasi or Christian facility at the community level, they are also deployed. So currently, if you look at the Upper East region, for instance, of Ghana, the entirety of the community level have e-tracker deployed. And it is a government system. Now, the funding is where the challenge is. It's partly funded by the government of Ghana in terms of the personnel training, deployment, but in terms of the acquisition of the hardware, in terms of the tablets, etc., we have some partner support. For the Upper East region, for instance, we have COICA, which has supported the deployment through a project in the entirety of Upper East region. If you take the CHIPS Learning System districts, then the funding for the e-tracker is by the project. That is basically the funding from Doris Duke Charitable Foundation and the Columbia University together with Ghana Health Service that are deploying. So that is how. So we are looking for other opportunities, and we have actually just compiled a total budget for the national deployment, and this is under discussion with government and other partners.
Wonderful. Thank you, Dr. Aounar. And we have another question for the North Star Alliance program. Can you speak about how you share data between countries and what the process looks like for the agreements between the different countries that North Star Alliance works in, and how data is shared between clinics?
Sure. So in terms of our EMR, so this is one that is basically installed in every Blue Box clinic. So the data is copied at the clinic level, and then it's linked to a central server. So we do have offices in Kenya and in South Africa where the data is synced to the regional office and also to our headquarters office in the Netherlands. So we do sign MOUs with the Ministry of Health, but in terms of the data that is collected, it is all anonymized, it's aggregated, and in terms of how it's stored, it's on encrypted files. So we do, in terms of reporting to the Ministry of Health, all of that data is aggregated and anonymized, but in terms of the EMR, so this is a tool that we have developed and customized, and we employ in our clinics, and so basically we deploy in our Blue Box clinics. And so when we set up a clinic, we have that agreement with the government that we're using this cross-border EMR, and that's negotiated when we sign our MOUs with each respective Ministry of Health or Department of Health.
Great, thank you. And we actually have another question that just came in again for Dr. Awonar. How did the project help incentivize integration of programs for PHC and get programs and people to come out of their program or disease silos in support of PHC? Does data help do this, or can data influence the ability to bring programs together? Thank you.
That's a very interesting and a very, very brilliant question. It's not been easy to move from the disease silo concept of service provision to an integrated system. So what we're trying to do is to build the capacity of the lower levels to be able to manage that process by doing a lot of advocacy and explanation that we need an integrated primary healthcare system. Now, for the e-tracker, the e-tracker is positioned at the facility level. That data at the point of care is collected. So the issue about phone numbers doesn't come in. But let me also say that we have had silo programs over the years, and even though we are working towards an integration, it is taking quite a time to be able to address that challenge. But now that the service is integrated at a community level, the use of the e-tracker is actually bringing the integration closer than when we were using the paper register. You know, remember that the paper register, you have to have different family planning register, community entry register, you know, immunization register. So I talk about 26 registers. But with the e-tracker, you see all this on a dashboard, and it's very easy for them to understand and conceptualize that it is an integrated system, and therefore that partitioning is no more there as it used to be.
Great, thank you, Dr. Awonar. Our next question is for Jamie of Babel Rwanda, asking about kind of the process for getting patients to feel comfortable sharing their phone number, or really kind of building that trust and acclimating patients to this new mode of care delivered via mobile devices. Can you speak to that process a bit?
Sure, no problem. So that's a great question as well, given the sensitivity of data that we're handling. And oftentimes, actually, patients don't end up handing over their identification data to us directly. What happens is that when they say, when a patient is interested in using Bubble and they dial *811#, what ends up happening is they need to enter in their ID number in order to actually go through a verification process. And so that verification process is automated, and what we're doing is we're checking that person's ID against the SIM card that's registered against the ID, and making sure that the person's identity matches who they say they are. And then this is further verified during the triage process, where our nurses ask the patients, you know, what their first name is, last name is, which district they're calling from, and so on. That being said, I think some of the concerns around patient privacy and data sensitivity generally comes in our talks with government stakeholders as well, and this is something that we take very seriously. So in terms of how we handle data, all the data that we collect in terms of not just patient IDs, but also the consultation data and everything about the EMR recordings and so on, is stored locally on a server here in Rwanda and not on the cloud. And we make sure to sort of elaborate why we need patients' ID data when it comes to ID verification, because it also helps us prevent cases of fraud, for example, where because we're unable to physically verify the patient who is calling in as the person who they say they are, it's vital for us to actually use that data. So in order to make a short sort of answer, it's essentially that we lay out the case for why we need the data and then explain people through the process that we go through in order to handle it in a sensitive manner.
Great, thank you. We now have a question for Dr. Umi Nadeau of the YEXI-NA project, asking about the extent to which the YEXI-NA project emphasized feedback both from users and frontline health workers to inform PHC performance and accountability.
Hi, my name is Nikita, and I work with Melanie and Umi, and I'm just going to translate that to Umi, and maybe we'll work on the side, and maybe you can go to a different question and come back to us.
Great, no problem.
Could you just repeat the question, by the way? Sorry.
Yes, so the question is, I guess, the extent to which and the process through which YEXI-NA sought feedback from frontline health providers and users when designing this innovation.
Okay, great, thank you.
No problem, thank you. Great, and so our next question is for North Star Alliance again, on the work for building capacity among local staff to collect and use data to, with an emphasis on the quality and the impact of these trainings. I know the team on the line from North Star Alliance had to drop off a little early, so if you're still there, it would be great to hear your response, but if not, we can move on to the next question.
Sure, Allison. I can respond to that one. So we do a lot of quality assessment within the clinics on different components of our service delivery, from the operations management to the service delivery to the clinical component, and also to client satisfaction. And so there are internal tools that we use, and these internal tools are, for example, used on a quarterly basis, and each clinic is given a score out of 10. We also do get evaluation and assessments that are done by our partners. The Ministry of Health also does assessments of our, for example, HIV lay counselors to make sure that they're up to date on the latest HIV protocols. In terms of data, so this is something that actually takes up the bulk of our work, and in terms of one of our current challenges is balancing the data entry, capturing, and collection with the service delivery. So that is, right now, we haven't optimized that process within the clinic, but we do look at the data that is collected. It is often sanitized and cleaned at sort of these higher levels. And when we do find discrepancies, the issues are either workshopped one-on-one with the clinical officers and nurses and HIV lay counselors, or often we do capacity building workshops. So this year we were fortunate to receive actually funding from one of our partners to do a healthcare capacity building workshop on data curation, on data literacy, on data management, specifically for our frontline healthcare workers. So this is something that we're focusing on more and more. There are challenges in terms of, again, balancing the service delivery with the data. And one of the things that we try to do is to negotiate the inclusion of data entry clerks when we do get funding from our partners, so that we can have our clinical officers, HIV lay counselors dedicated and devoted to service delivery, and then have people that are specifically allocated to the data entry specific tasks within the clinics. But we do that workshopping, so either it's one-on-one or it's workshopped in the sort of Eastern Africa region or in the Southern Africa region.
Great, thank you. And so our next question, so let's check in with Dr. Umi. Is that?
Hi. Yes, I have an answer, and I don't know if it answers 100% what the question was, but basically, once the program was already designed, then we had information and training sessions with the healthcare workers at all levels, and we have been getting their feedback via various evaluations to find out if it's working for them, and it has been generally very well received on their end.
Wonderful, thank you. And I also just want to note for listeners that there might be some more information about each of these cases, or just additional information than what was presented here in each of the case studies. So we encourage you, if you have questions that we weren't able to get to today, definitely take a look there, and feel free to email additional questions if they arise. But so since we're just about at time, we have one last question that is actually directed to the PHCPI team about the vital signs profile. So Dr. Hatt, how can we use the vital signs profile for monitoring community health programs which are not implemented at the pan-country level?
Sure, that's a great question. And so far, we've only been using the vital signs profile at a national level, but this is definitely a priority for us going forward. Something that we want to do is try to adapt the tool to be able to reflect subnational indicators and specific concerns that individual countries may have that they want to measure at the subnational level. What I would encourage you to do, actually, if you go to our website, improvingphc.org, you can see the vital signs profiles for the first 12 countries that we've collected, and each of those kind of overview scorecards has a second backup sheet that you can click into, giving more detailed, granular indicators. And specifically in the performance domain, where we look at access and quality and service coverage, many of those indicators could very easily be measured at a subnational level, and through routine data sources, not just through surveys, which tend to be implemented less frequently, of course. So some of the dimensions around continuity of care, person-centeredness, competence of providers, safety, those types of dimensions are reflected in those more detailed scorecards. So I think that's probably where it makes sense to focus for individual community-level programs. But stay tuned as we continue to try to expand the application of the vital signs profiles at a subnational level.
Wonderful. Thanks, Dr. Hatt. And thank you to all of our presenters today for taking the time to share more about these innovations with us, and just for being willing to participate in this report and this webinar. We appreciate it a lot. And of course, to all of the listeners as well. It seems like that is all the time that we have today. So we're going to wrap up. But if you have any additional questions, please feel free to email them. As I mentioned, this webinar was recorded, and we will share out a recording and can also share a link to where the original report lives online in case you have not yet had a chance to flip through it. Thanks, everyone, and have a great rest of your day or a great evening, depending on where you're calling in from. Bye.